17 women died either while pregnant or during childbirth last year in Guyana, according to the country's chief medical officer, Dr. Narain Singh. Those deaths are categorized as maternal deaths. The first death was recorded at the Georgetown Public Hospital, Guyana's main referral hospital located in the capital city. It was a 25-year-old woman who died on January 11th. In the weeks and months that followed, several other women died. Because of patient confidentiality in the healthcare system, we don't know who many of those women are. But in a few instances, concerned family members have come forward and spoken about the loved ones they lost and even questioned if enough was done to prevent their deaths. That was the case of 16-year-old Dana Pestano, who on May 27 died while 6 months pregnant. The results of an autopsy were inconclusive, but her mother, Diana Pestano, believes that much more could have been done to prevent her death.
When she holidays, when all the doctors them run wrong and then they start hustling for do this and do that, but it was already late. My daughter already died. And when we go to the hospital, they transfer her to Georgetown Hospital. That was about, we reached Georgetown Hospital, must be like, I can't remember the time, but it was afternoon going into nighttime, right? I must suggest must be near 7 or a little after 7, I can't remember. And when we reached a Georgetown Hospital, the ambulance never stopped properly and I jumped out because I just praying all the time that something, and when I jump out the ambulance and I run to my daughter, when they're pulling her out on the stretcher, the first thing I saw was my daughter's hand and all here, it done blue. So all her fingers, them, they done blue. And they lied to me and tell me how, when she reached one of the doctor at public hospital, said them not finding any pulse. So I asked them, what do you mean? They said that they ain't finding no heartbeat or nothing.
Based on information provided to the newsroom, Castano's death was classified as an indirect death. In simple terms, indirect deaths occur when the person experiences some challenge unrelated to their pregnancy, such as a COVID-19 diagnosis, another health complication, or an unfortunate accident. Following further tests conducted overseas, it was found that the teenager died due to complications associated with her pregnancy at a young age. At least 9 of the 17 women who died were classified as indirect deaths. The remaining 8 were classified as direct deaths, which means that it was caused by some factor relating to the woman's pregnancy. Dr. Singh told us more about this.
So last year we had 17 national total deaths, and 8 of them were actually direct deaths. And this is because of some complications during the pregnancy. So some of them, at least most of them probably happened at the GPHC, unfortunately, because this is the primary referral hospitals for high-risk pregnancy cases. Some of them are, most direct maternal deaths are sometimes preventable. Problem is, when we dissect maternal deaths, we can actually put them in 3 broad categories. 3 reasons why maternal deaths happen, direct maternal deaths. One, we call it 3 delay model. One is delay, the first delay is in the patient seeking care. The second delay in them accessing, getting to the healthcare facility. And the third delay is when they're in a health facility, some delay in getting medical care. So if you were to look at the different causes of maternal death, direct maternal deaths, you can actually put them in one of those categories. Last year we had one unfortunate death where the patient actually tried to deliver at home. She didn't want to come to the hospital and tried to deliver and ran into problems. She didn't seek and even didn't go to antenatal care. So there was a delay because of seeking care. Sometimes because of when they do get into labor or get into complication, the travel distance, is so far transportation issues and getting to facilities sometimes is one another delay. That's why we're doing these maternity waiting homes to help to reduce that. Sometimes we have to air dash medivac a patient from the hinterland to Georgetown. Sometimes because of the terrain and lights and weather bad, where you have to delay, sometimes they come and that can cause a delay in them getting to the facility. And the third delay, sometimes they're actually in the facilities or something went wrong or they weren't, some mismanagement or something can have happened with the case or the conditions wasn't recognized and that can happen too. So
did that happen last year, any of that?
We had 2 cases where we thought that the patients were in hospital and because of management, the management issue, how the patient was managed probably result in could have been prevented.
Do you know which of the cases are those?
I don't want to, because those cases are actually being investigated presently. Depends upon if anyone is found culpable. But the idea of maternal death is not really to penalize someone. It's to identify where we have the weaknesses and put corrective measures in place.
Whether directly or indirectly caused, maternal deaths in Guyana cause much outrage. That much is evident from social media comments, for example. And maternal deaths, when reported, seem to generate questions about the quality of maternal care provided in Guyana. So despite gains made in years gone by, health authorities are keen on improving maternal care. In fact, Health Minister Dr. Frank Anthony said a Canadian team will this year travel to Guyana in search of potential gaps and shortcomings in the maternal care offered.
Next year we have a team of professors from McMaster's in Canada. We have a team from the UK who would be coming to Guyana to help us do a comprehensive review to see whether or not we're missing anything. And they would also be supplementing with some teaching and strengthening and looking at how we can strengthen our systems. The ultimate goal of all of this is to prevent maternal deaths. In addition to that work that we'll be doing with McMaster's, McMaster's has opened up to us for us to send doctors to do fellowship training in Canada. And so starting next year, we'll have one of the doctors going up to McMaster's to do a 3-year fellowship. And again, when they come back, to bring that culture and to help to improve standards here. So it's a lot of, we know that we have an issue, but we're working to make sure that we reduce the incidences of maternal death. And, we have to keep working at this.
Ahead of that assessment, though, some solutions are being rolled out. The construction of maternal waiting homes, especially in hinterland regions where communities may be located far away from hospitals, is one such solution. The facility behind me, the Amerindian Hostel in Georgetown, is one such waiting home that allows pregnant women to stay near a hospital just before they go into labor.
So one thing we are trying to do with that is to build these maternal waiting homes. Maternal waiting homes are small centers close by to the hospital where a woman who's pregnant and near term or time to deliver, they come close by to the hospital, because in the hinterland we know one of the challenges to get to these facilities when they're ready time to delivery, because of how far they live in the geography of those regions.
How many of those facilities do we have?
So far we have about 6 of them, right? Presently in operation. We have in Region 9, we have 2, we have 1 in Region 1, and 2 in Region 2, 1 in Region, 2 in Region 1, 1 in Region 2. Region 4 have 2. We have the Amerindian Hostel that we use for Georgetown. And the Region 10 has 1. So we have several of them scattered abroad the country, mainly in the hinterland regions, because that's where our biggest challenge is, because of the location.
Are you pursuing more of those?
We're looking at some areas, some in hinterland regions, like in Region 7 and Region 8, which has the population is widely spread to get them closer to the hospital at the time of delivery.
Right.
That model is actually working well, because many women are actually coming to the hospital, and when the time for delivery, they're in a hospital so they can be delivered.
Importantly too, huge focus is being directed towards ensuring that more women can access antenatal care. With much needed checkups during pregnancy, the Chief Medical Officer and obstetric gynecologist himself believes potentially fatal conditions can be readily identified and managed.
One of the things to do is to improve have access. The men should have access to antenatal care in all the 10 regions. It's a ministry policy that every pregnant woman should at least have 4 antenatal visits during their pregnancy. And we are trying to ensure that happens. And they should be seen by a medical officer or someone who's trained at least once during their pregnancy. We are also implementing that they should at least get an ultrasound done at least once during their pregnancy. And so those are some of the things we are trying to help improve antenatal care. The other policy that we have in place is that every pregnant woman should deliver by what we call a skilled birth attendant, and in a facility that is capable of doing those things. Presently in Guyana, the numbers are like about 96% of all women deliver in a facility that is where they're delivered by a skilled birth attendant. That means somebody who's trained and in a facility that can handle delivery. When we disaggregate the numbers, the figures, we see sometimes in the hinterland region, that's not always because of access to health facilities and so on.
Constructing or operating theatres in the regions is another effort authorities believe will improve maternal care, particularly in offering women much safer caesarean deliveries. A new women and children's hospital is also being constructed, and this has been touted as a facility that will provide key specialized services. With these investments, Dr. Singh posited that maternal care is a local priority.
Maternal mortality is something that is a good indicator of your health system. How it's like a litmus test of your health system. And many international organizations use the maternal mortality ratio as a litmus test of how functional your health system. So it not only reflecting maternal health alone, but it reflects how good your health system is. Because if you look at maternal health, it passed through the different levels in the system. And it's a test of how good your system is. And so if you see maternal mortality is improving, you know the health system is improving. And now with all the investments we're having in place, we hope to see a downward trend and to achieve that SDG goals where we can have minimal maternal deaths. Because, I mean, there's a saying, WHO had a program that no woman should die giving birth. And we hope that we can achieve that at least. All things not equal, some deaths are sometimes unpreventable sometimes.
Reporting for the newsroom, I am Prashani Raghavar.